We have a lot of attendees, so thank you for joining us this evening. And it gives me great pleasure to welcome up one of the industry's leading experts. We had a lot of different titles that were thrown about for this webinar. And actually, the initial title for the webinar was about discussing IUI versus IVF. And the reason we actually changed the title of the webinar to say, how to decide when and if you need fertility treatment was that somebody said, is that the same as an IUD to me? And I said,
Okay.
no, no, an IUD will not get you pregnant. IUI
Yeah.
will definitely get you pregnant. And I think this sometimes can form part of the troubling narrative is that when you become so inured and so used to the terminology, it actually becomes part of your common vernacular, and it makes you forget that so many of the terms that we use in fertility and infertility and IVF, and certainly some of the statistics, simply aren't known by so many people. So I thought this would be a perfect opportunity for us to break down some of those terminology, and actually we changed the title so that we would go back to basics. Dr. Tim, you are one of the names that everybody knows. You have been around and been one of the leading voices in not just fertility treatment, but also putting together some of the most important guidelines that every clinician uses. So it's a huge honor for me to be able to share a platform and to just speak to you about all of your clinical expertise. You and I are both affiliated with an organization, and sometimes people then assume that that means you have a vested interest. And I think the first disclaimer I want to make is that while I am affiliated, of course, with Hertility and you are affiliated with Apricity, that our backgrounds and our education are of individuals who are really dedicated to actually just knowing more. And so I think I just wanted to, sometimes people think that when you put together a webinar like this, it's with the view to bring somebody to fertility treatment. And actually, both of us in our work have done a lot to help people avoid
Yeah.
fertility treatment and to help mostly just them to understand. So you have a very accomplished CV and bio. So if you'll forgive me, I'm just going to take a moment to so that everyone understands just a little bit about your background. As Chief Medical Officer, you're also Associate Professor of Reproductive Medicine at the University of Oxford, and the clinician on the National Institute of Clinical Excellence, or the NICE committee, which developed the NICE guidelines setting out evidence-based recommendations for investigation and treatment. So that was a hugely important piece of work that you did. And in 2008, you co-founded the award-winning University of Oxford MSc in Clinical Embryology, really showing your dedication to education and educating the people who are the most important people in any fertility journey, really is the embryologists who
Yeah.
holds the magic when it comes to procuring those embryos and gametes. So in 2021, you were appointed by the Secretary of State for Health to the board of the Human Fertilisation and Embryology Authority, which is the UK's regulator of assisted conception and treatment and research. And you chair the Scientific and Clinical Advances Advisory Committee, or the SCAC committee, responsible for IVF add-ons at traffic light system. And this is very important too, because what it does is it enables us to say, what are the proven treatments, what are the unproven treatments, and how can we really garner the people just going for treatments that are not necessary
Yeah.
for their journey. So you co-founded the Fertility Partnership, Fertility, and as Group Medical Director, helped grow it from 2 to 20 IVF clinics across 6 countries before leaving in 2023. And were recently awarded the Lifetime Achievement Award by the European Fertility Society. So it's an
That
understatement.
just that just means I'm really old. I've been around for
No.
too long.
Well, it means we're really happy to have you here, and I don't think there's any question that anyone is going to ask that you won't be able to cover. So thanks a million for joining
There
us
we go. Okay,
this
thank you.
evening.
Well, thank you for the invite, and it's certainly good. I think your introduction as well, sort of saying that we're here to take questions from people on all aspects of fertility. Absolutely. I might not know the answer, but if I don't know the answer, I'll say I don't know the answer, and I'll give a good go at it.
Exactly, exactly. So it's great to have you here. We have a few slides just of an introduction
Yeah.
to fertility, some of the statistics, and an introduction for myself. I am an associate professor in reproductive and molecular genetics at University College London, where I lecture both masters and medical students in reproductive genetics and the early genetics of embryo formation. and genetic engineering. And I am the founder and CEO of Hertility, which aims to give people clarity into their fertility and the onset of any reproductive pathologies. So our aim was to build the largest database of its kind, so that we could essentially effectively triage people for infertility prior to going through a fertility journey, to find out what was the root cause of any infertility by looking at different factors, whether it's menstrual factors, biometrics, lifestyle factors, your hormones, your ovarian reserve, and just to get a much more clear picture from the overall health perspective. Because the statistics are scary, and that's the first thing I will say, is when we show these statistics, they are kind of scary. And actually, there's the reason I think we started Hertility and we've gone to this journey is because of these statistics being quite scary. And as a woman in my 30s, they were definitely scary to me, thinking maybe I am the exception and maybe I'm not the rule. So we'll just get started. Just a disclaimer and trigger warning, both of us are here to answer as many questions as we can cover, but please don't substitute this for medical advice. It is for educational purposes. There are plenty of resources that we have between both of our establishments and us available to you should you need anything. Please do reach out, and we are more than happy to connect you with the right people for that and connect you with the right services too. So just an overview of what's covered. We're going to cover what is infertility and the causes of infertility. This is mostly because when we did a session with Google to see what is it that people were searching for when it came to fertility, the number one search wasn't any of these, what is IUI, IUD, what is IVF? It was actually, what is fertility? And that was a real eye-opening moment for me to think that people don't actually understand what fertility is, and therefore it can be misleading or confusing on a journey to understand what is infertility. So we'll have a look at that, and then we'll take a closer look at some of the fertility treatments, such as the clinical indications for IUI or intrauterine insemination, IVF, and how it works, how your lifestyle can affect your fertility, and how just to feel a little bit informed. So hopefully you're going to come away from this webinar feeling like you're a bigger expert than our company here. So we'll start with infertility, and it sounds very simple to say that a successful and healthy conception requires just a few ingredients: a healthy egg, a healthy sperm, successful ovulation in order to release that healthy egg, successful fertilization when the sperm and egg meet, and a successful implantation of that embryo. Actually, in reality, despite the fact that this should be the most simple thing in the world, it is a very complex there's very complex biology behind it, and it's not as easy as everybody thinks, not least of which because we aren't ovulating all of the time, despite this narrative that we can get pregnant at any single time. But understanding the background and the individual parameters that lead to a successful conception can help you start to break down what are the barriers to conception if you are struggling to conceive. And here are just some of the definitions around infertility, which is a disease of the reproductive system defined by a failure to achieve a clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. But infertility can be both primary and secondary. Primary infertility is when somebody has never achieved a pregnancy. Secondary infertility, you may have had one or more pregnancies in the past. You may have children already, but you're having difficulty conceiving again. And it's important to understand that you're not alone if you are struggling. Actually, 1 in 6 individuals suffer from infertility. It is a global epidemic of infertility that we're witnessing, and with declining fertility rates all over. There's 3.5 million in the UK who are affected, and 1 in 4 cases are actually unexplained. And around 30%, though we love to say that this is a female factor thing, actually in about 30% of cases, both partners are affected. And about 16% of couples fail to achieve a pregnancy after a year. So actually, the reason the year is set out is that a lot of people do tend to get pregnant within that 12 months. But earlier knowledge about that means you may not waste 12 months trying if you may have been struggling for that whole time with something structural. So there's lots of different causes of male infertility, from sperm and semen to damage to testicles to pituitary disorders that can affect your production of steroid hormones, to ejaculate problems. Then there's iatrogenic causes and lifestyle factors, and also genetic conditions. So what you see here is this large picture of many different causes for male factor infertility, and this is compounded by the different causes of female factor infertility, which there are 11 listed causes on the National Institute for Health's website, from age to uterine factors to cervical factors, ovarian and ovulation to tubal factors. So it stands to reason it was when looking at both of these that I really felt that this compulsion to say, how is it that we can start to eliminate what are the risk factors that any one individual might have? And it's only when you start to rule out some of these different things that you can really find the root cause of one or other of the causes of infertility. Okay. This is definitely by no means meant to make anyone feel anxious, just to know that there are ways that we can look at different factors to find out the root cause. Now, Dr. Tim, over to you to explain a little bit about how IVF itself and what IVF is and how it can help certain individuals conceive, especially if they have any one of these different conditions.
Yeah, thank Helen. Is this sound okay? Because I could take the headphones off if is that okay there. So yeah, so thanks Helen for the introduction there and the background to what is fertility. And as you said, I was involved with a NICE guidelines group that put together the current guidelines that are still in place, and we were very clear that in keeping with the WHO, it's really 12 months of failure to conceive. And as you said, about 80 or 90% of couples do actually conceive of heterosexual couples conceive over the first year or so. But even, I think, very important point is that even those that don't conceive over the first 12 months or so, about half will conceive in the second year of trying. But it's really important that all the tests are done to make sure that there's nothing there which is going to stop them conceiving, and therefore perhaps should move on to a treatment such as IVF. So I don't know how many of you have watched Joy yet, the film on Netflix that came out last week. I was lucky enough with many others. I think most people who work in IVF were there at the premiere back in about a month ago. It's an amazing film, and it really shows you the struggles that the team of three went through back in the 60s and 70s to get to the point where what is on this slide, the IVF slide, now is seen as almost like a standard treatment with a good success rate. But the main part of IVF, and IVF was developed back in the 70s really to treat a problem of blocked tubes or absent fallopian tubes, because with IVF, as we see on here, we avoid the tubes, we go around the tubes. But nowadays, IVF, the success rates, it's been recognized to the same, really regardless of what the cause of underlying fertility problems are. Now, the main part of IVF is the ovarian stimulation. So that is normally about 10 to 14 days of a daily injection to stimulate the ovaries. If you just gave the ovarian stimulation, then the woman would ovulate. All the eggs would go. And that was part of the problem with IVF back in the 70s. There was no way of preventing women ovulating and losing the eggs, which is why they were doing egg collections at 3 o'clock in the morning on a Sunday. They had to get in there before they ovulated. And during the 80s, it was recognized that there was a drug you could give to prevent the woman ovulating. And that's the bit on the top left there, which is a downregulation. So some people will have heard of a long protocol or a long agonist protocol, in which you take a drug for 2 or 3 weeks to switch everything off, then you do the ovarian stimulation. But nowadays, most IVF cycles will be a short antagonist protocol. So on day 2 or day 3 of a period, you'll start the daily ovarian stimulation injections, and the dose will be decided based on your ovarian reserve, which I think we'll come on to. But you have to have a second drug to switch off ovulation, and that's the daily antagonist drug that you take alongside the daily stimulation drugs. After the 10 to 14 days, there's then an egg collection, which is done under sedation in the IVF lab, in the egg collecting room next to the IVF lab. And it uses a vaginal scan probe with a needle on it. And the needle goes into the follicles and the eggs are collected. Around the same time as that, if a fresh sperm sample is being used, then the man produces a sperm sample and it's prepared in the andrology lab, part of the IVF center. Or if frozen sperm is being used, perhaps because it's donor sperm, or maybe it's sperm that's been taken from the male partner by a biopsy, for example, and it's frozen, it'll be thawed out. And then on the same day as the egg collection, normally sort of 3 or 4 hours after the egg collection, the eggs are inseminated. So the eggs and sperm are put together. If the sperm quality is normal or is good, then conventional IVF is done, and the eggs and the sperm are just mixed together in the lab and then left overnight. And then the next day, the embryologists come in to see what proportion of the eggs have fertilized, and it's normally about 2/3. If the sperm quality is reduced, or if it's come from biopsy sperm, then doing conventional IVF and just mixing eggs and sperm together won't work. So the sperm has to be injected into the eggs, and then one sperm would be injected into each egg, and that's a procedure called ICSI. Again, it gives about 2/3 fertilization rates. The fertilized eggs, and they're now called embryos, are then cultured on in the incubator, and many centers will use time-lapse incubators, but there's different types of incubators that can be used. And nowadays, most centers would be culturing those fertilized eggs, the embryos, on for 5 days to what's called the blastocyst stage. And then at that point, if you're having a fresh embryo transfer, then normally the best single embryo is transferred, sometimes 2 embryos, but normally 1 embryo. And then any spare embryos of suitable quality can be frozen for later use. If, though, perhaps you're not having a fresh transfer, maybe the plan has been to freeze all of your embryos, or perhaps you're having embryo biopsy to test the genetics of the embryo, then the biopsies would be done at the blastocyst stage, or everything would be frozen at the blastocyst stage, and you might then come back a few weeks or months later to have the embryos thawed out and put back. But if you're having a fresh transfer, the embryo transfer is done under scan guidance. So it's a bit like having a smear test. So a speculum is used to get a clear view of the cervix. And then the embryologist will then load up the embryo in a soft catheter, which goes back through the cervix by the doctor or nurse under scan guidance. And then the embryo goes back. You do a pregnancy test about 2 weeks later. And then hopefully, if pregnant, then a pregnancy scan a couple of weeks after that. And that's an IVF cycle.
Okay. I think a lot of people get so pent up on the timing of all of this. Like, how long does all of it take? It all seems so insurmountable, especially I think when we use images like this. Can you just give us a little bit of a definition of what is physically going to happen to me? I do my fertility test and I find out that I'm going to have to go through IVF. That at least saves me the cost of doing bloods in the clinic, and I can go to the clinic. We're then going to set up that stimulation protocol, and you talked about a long and a short and an agonist and not. But essentially, what is happening to me? We're definitely gonna stimulate my ovaries and try and replicate a normal menstrual cycle, except 10x it or more, and say instead of just releasing 1 egg every single month, we're going to give me additional hormones, so that instead of just one of these follicles in here maturing, we get as many follicles as possible maturing and being able to be collected. But how long will I be injecting myself? What's the protocol there?
Well, it basically, I mean, because as I mentioned, nowadays most clinics will be using a short antagonist protocol. Really, the duration is the same as a natural menstrual cycle of trying to get pregnant. So you'll start the stimulation on day 2 of a period. The egg collection is done about 10 to 14 days later, so around the same time as you would ovulate if you had a 28-day roughly cycle. And then the embryo transfer is done 5 or so days later, and then you'd be doing the pregnancy test about the same time as you would do if you were getting pregnant naturally. So nowadays, an IVF cycle happens very much within a 4-week period if you're having a fresh embryo transfer, i.e. the same amount of time as if you were looking to get pregnant naturally.
Exactly. So I think that's something that people really, just with the unknown of everything, with finding a clinic, with the cost, with whether they should do it or not, with what the protocol actually involves, all of this seems very scary. But when you break down the timing of it, actually, it's start to finish like a normal menstrual cycle. You have injections for 2 weeks. And after that 2 weeks, essentially, and you've had your egg retrieval, which is really done under mild sedation, and you're kind of out within 20 minutes. Really, the bulk of the invasiveness, the most invasive business, which is injecting yourself once a day, is going to be done in 2 weeks. And then really the fate is in the hands of the specialized embryologists.
Yeah, and I think again, IVF, I mean, compared to when I first started doing IVF way back in the 1990s, it has become so much more simplified. So it's much more straightforward now than it was then. As I mentioned at the beginning, on this slide, it shows down regulation at the top left. And most centers don't do that now. So it's much quicker, it's much more straightforward. It used to be that the drugs had to be mixed up with water and powder. And now generally it's all a pre-filled syringe, and it's a multi-dose. So the clinic will be telling you what dose to take every day of stimulation. And say, for example, you're on 150 units of whichever drug it is, you dial it up on a pen. It's a very small needle, like a diabetic needle. It's a subcutaneous needle that goes into the skin of the tummy or thigh. People give the injections themselves. You don't generally need anyone else to give the injection for you. And indeed, it's best to do it yourself because you're then not dependent on someone else getting back from work or not being away for travel or whatever. So it is that, yeah, the time scale is the same as a natural monthly cycle of trying to get pregnant, but the big difference is the success rates are so much higher than the success rate of trying to get pregnant naturally. Even for a fertile person, they're higher than that. And that is where, if you also look at having more than one IVF cycle, so perhaps having a few cycle time period, the chance of having a success from that IVF is essentially higher than natural success rates. And that has been the huge change over the last 10 to 20 years, really. It's been that ongoing increase in IVF success rates.
Yeah, yeah. So let's talk about what you might want to consider before IVF, which is intrauterine insemination.
Yes, IUI is interesting. If I think back to, again, when I started in the Oxford IVF clinic back in the 1990s, back then we were doing, and I was thinking about this earlier on, we were doing 1,000 IUI cycles a year, and we were doing maybe 600 IVF cycles. So we were doing loads more IUI than IVF. Now, what IUI is, so IUI is intra, which means inside. So it's intrauterine, which is the womb, insemination. So as it shows on the slide here, what happens during an IUI cycle is there's a sperm sample, which might be fresh sperm sample from a partner, perhaps if it's unexplained infertility, or most commonly nowadays, it's donor sperm. So it might be thawed donor sperm. And the sperm is washed and it's prepared and it's concentrated. And essentially the lab are taking the best quality sperm from the sample. And that is then injected up inside the uterus, which is the inside uterine insemination. So it's better quality sperm, it's past the cervix, and you don't need any sedation. Again, it's like having a smear test. It's a very, very quick procedure. And the idea is that it's sperm of better quality, better motility, which is closer to the egg, because you can see there on the slide that the sperm is pretty much half the distance up to the egg. Now, you might think, therefore, that IUI is an amazing treatment because it's got all of the advantages of better sperm closer to the egg. But in the UK, IUI really dropped out of favor. And I'm talking more for heterosexual couples here with fertility issues. It really dropped out of favor when the 2013 NICE guidelines came out. And again, as mentioned, I was on the committee that was involved in that, because at that time we looked at the studies for heterosexual couples with infertility. We looked at studies where they were randomized. So the study either put them into IVF or IUI, or we looked at studies where people had either IUI or just tried naturally. And what we found was that there really weren't any more babies being born following IUI compared to people trying naturally. And so we said that really the NHS shouldn't be funding IUI, and it stopped very, very quickly for most people. So IUI dropped down significantly, but as you mentioned in the introduction there, Helen, I've also been medical director of clinics in 5 other European countries outside of UK and Ireland. And on the continent, IUI is used very, very widely because they feel that it's a stepping stone into IVF. Now, my sort of feeling is that if IUI is going to work for people in heterosexual relationships, that perhaps if they're just tried a bit longer naturally, it also might have worked naturally. Because the problem with IUI is not really treating anything. So IVF, where we're making the embryo in the lab, we can see what the quality of the embryo is. And very importantly, when you have an IVF embryo transfer, we know the embryo is going back into the uterus. When you do IUI and you're injecting sperm up into the uterus, you never actually know that the egg and sperm meet. You don't know that an embryo is being made. You don't know that the embryo is making it to the uterine cavity. You have to have normal fallopian tube function. So if there's some subtle problem with the tubes in IUI, maybe the egg and the sperm aren't meeting. So in my view, and currently the view of NICE, for heterosexual couples, unless there's some sort of psychosexual issue, which means that they're unable to have intercourse, so therefore IUI is treating it if you can't have intercourse. But for most heterosexual couples, I feel that IUI isn't really adding a lot. But if you're using donor sperm, that's completely different. So for donor sperm, whether it's for heterosexual couples or same-sex female couples or single women, or so, solo women, then IUI with donor sperm can be very successful, because obviously in that situation, it's treating the absence of sperm in the uterus. So under that situation, under that scenario, there certainly can be a place for IUI.
Excellent. I think you covered everything when it comes to that there. And actually, it's the reason, part of the reason why I wanted to show in the beginning all of these images that essentially show the multifactorial causes for infertility, are that we so often think of fertility as being this black box. Like you said with IUI, you can put the sperm in, but you don't know whether fertilization has occurred. You actually don't know whether the sperm and the egg have met. And actually, when you take into account all of these different parameters, it enables you to start to some extent, troubleshoot. But in the incidence of a solo a woman undergoing solo motherhood or same sex, if there is no underlying problem, then actually you're just essentially creating the opportunity for sperm to reach.
Yeah.
At least we hope. Okay.
Yeah. Yeah.
So I just wanted to take a minute for our predictive algorithm. We have really spent the last 5 years building this because of that very question, and that is, how do we understand whether or not somebody has something wrong with them? And when we look at some of the data and the clinical guidelines that are used to inform clinical diagnoses of different pathologies, they're not based on huge amounts of data globally. They're not, and so what we wanted to do was to take into account as many different factors and parameters as possible when it comes to assigning an individual with a suspected diagnosis of a pathology. So in the health assessment for the Hertility test, we ask a lot of different questions around menstrual factors, any symptoms, lifestyle factors, any previous diagnoses, any previous infection. And all of those are actually quite powerful predictors in assigning us a suspicion of a different pathology. And what we do is, if we suspect that you have a pathology that we could confirm with additional analytes, we'll test you for additional analytes, including the standard analytes that we will test, which are your ovarian reserve, AMH, your thyroid health, and your ovulation and period hormones. So your luteinizing hormone, your estradiol, and your follicle stimulating hormone. Excuse me, I do have a cold, so I'm actually quite sniffly. But in this health assessment, it shows us the power of using a lot of data to better inform a clinical diagnosis, and just to get to somebody to appropriate care a little bit sooner, using large amounts of data of people who have a previous diagnosis. What we're really starting to see, and maybe we can work together with the NICE guidelines, are to say, actually, some of the well-known predictors aren't powerful predictors on their own, but some of the less well-known or unknown predictors in isolation are quite powerful predictors of a given pathology, especially in combination with others. So we've built predictive algorithms for 18 different pathologies based on over 540,000 women's health assessments to enable us to predict different pathologies. And we've tested this using machine learning. We've tested how well we could have predicted these pathologies, and we've tested it against clinicians. The model performs with 98 to 99% confidence with both precision and recall for 18 of these different pathologies, from PCOS to endometriosis. And what we're not doing a diagnosis, we're doing a screening with high confidence to say you may have a pathology, and now we need to get you to somebody like Dr. Tim in order to assess you in a more timely manner, rather than waiting this ongoing time to say, actually, maybe you might not get to a diagnosis for a very long time. It's quite infuriating, I think, as a health professional, when you look at the long diagnosis times that women experience and the delay to getting a diagnosis for very prevalent conditions. And so I'd love for you to just tell us a little bit about the fertility predictors that you have built at Apricity as well.
Yeah, so I agree with you. I mean, certainly, from the NICE guidelines perspective, they generally talk about having investigations or going to see your GP after 12 months of failures to conceive for heterosexual couples. But they do mention, if you have irregular periods, or you're concerned about something, or you've had previous fertility issues or surgery on your pelvis, there's a whole list of things anyone can see on the NICE guidelines site, that maybe by 6 months, or if you're in your later 30s or beyond, that by 6 months it's worth having some tests. But it can be very difficult to get those tests, particularly at the moment, via GPs. And the GPs are busy doing all sorts of stuff, and may also, in my experience, say, well, come back at 12 months, come back at that point. So I think having access to and a big change in the last few years is being able to have access to testing, whether that's via Hertility or Apricity or what have you. That sort of testing of hormones, the test done at home and sent in, then you get the results sent back to you. Now on the Apricity website, then there is a fertility predictor, and what you can do is you can put in your age, your fertility history, a bit of information about your menstrual cycle as well, and it will give you an idea based on those parameters as to what your likely natural chance of conception is, because certainly female age and fertility history are two very, very important predictors of the chance of conception going forward, which can obviously be refined further once you start adding in some of the hormone test results that you've mentioned there, Helen. And on the Apricity website, there's also a treatment predictor. So again, you can put in details such as your age, fertility history, pregnancy history as well. And based on over 500,000 cycles of data from the HFEA, which is the UK regulator of fertility treatments, then we give you a likely chance of success, you personally, with a treatment such as IVF.
It's amazing that we can use data to better inform some of these outcomes finally. And it's I think the reason I feel quite passionately about using data to better inform an individual outcome is that the generalized statistics can be really misleading and can be terrifying. So when we see from our data, when everybody asks, I'm sure the exact same question you get asked all the time is, what are my chances of getting pregnant if? What are my chances if I freeze my eggs? What are the success rates when I freeze my eggs? What are my success rates if I freeze my embryos? And actually, I always, whenever I get asked about success rates, to me, that's a bit like asking somebody, what are my chances of getting better if I'm sick? First thing you would say is, what's wrong with you? What's your underlying health? What's your lifestyle? What's your genetic history? What medication are you already on? All of those different parameters contribute to your individual chances of getting better if you're sick. And it's no different to a fertility journey. What is the success rate for you as an individual if you are 35 versus 30 versus 25 could be hugely different depending on your underlying health.
Yeah, absolutely.
So there's a QR code here that you can book to speak with any advisor if you have any further questions. And I don't have any further slides after this because I thought we could just dive into some of the questions that people might have. I actually, while we were talking, I was trying to get into the Q&A section here. While I just try and find the Q&A. Tim, can you see the Q&A questions? It's on
It's at the bottom when I hover. I can see it when I hover my mouse over the very bottom.
You able to see the questions. We actually published a proactive guide to getting pregnant, which might be useful as well, and a same-sex guide to getting pregnant, so that we can send all of those in the follow-up email from this. And I'm just gonna stop sharing. Oh, here I have them now. Sorry, they were on a different screen. Okay, great. So we'll start with what's the definition of regular unprotected sexual intercourse for the purpose of defining infertility?
Yeah, so I mean, well, the recommendation from a guidelines perspective is intercourse 2 or 3 times per week through the cycle. So at the moment, there's not a suggestion that people try and time intercourse. This is for heterosexuals that try and time intercourse based on urine ovulation predictor kits. So it's really, the nice guidelines are 2 or 3 times per week through the cycle. And would be regular unprotected intercourse. That's what the definition would be.
And actually, I recently read something about our immune response if you're only having sex when you're ovulating, that your uterus is, or your cervix is more likely to view the sperm as being kind of a foreign object, which it is, and to host an immune response that rejects it as opposed to becoming accustomed to the sperm. And I thought this rule must have been made up by a man.
I think the issue with timing is if the tests are not 100% accurate, the urine LH surge testing, and if you're purely using that for timing, there's always a risk maybe of it missing ovulation or what have you. Some women will say they like the data they get from checking for ovulation, but some women will also say that it just adds an extra layer of stress. And because the data is not really there saying they should be doing it, I say if you like checking for ovulation, great. If you don't do it.
I'm a big fan of getting to know your cervical mucus. So when you've ovulated, like personally, some people get like an ovulation pain, and once you've learned that you get ovulation pain and that it alternates between each side of your ovaries, then the cervical mucus will accompany that, and it's like the egg whites, and everyone's like, Helen, please don't talk about this like this. But I think everyone should become very attuned with their own cervical mucus. I will say it as many times as it makes people talk about it. Okay, great. So what is your advice about using intravaginal insemination? So syringing seven into the
Semen, I think it's a spelling mistake. Semen,
yeah, into the vaginal canal. Do you think is an effective method, and are there things you should be aware of? It seems like to be a good alternative to help take the pressure off men to ejaculate during intercourse.
Well, I guess there's a few things there. I mean, certainly the home insemination has obviously been, it's been around forever, and there's a lot of babies will have been born from home insemination.
Used to be
In
called the
terms,
Hertility method.
yeah, exactly. There's a lot of if that's something that you're interested in, then if you speak to the chemists, pharmacists, they will have probably access and advice on particular kits to use for that. I suppose there's a few things there. I mean, that question to me as well, the last line about the pressure off men to ejaculate during intercourse. I mean, if there are some issues there with that, which are quite common because of the pressure side on men and women in heterosexual relationships from a fertility perspective, I think I'd also take a step back and see, well, is there a place for some psychosexual counseling? Because that's a bit of a flag there for me that maybe there could be some help offered to help support that couple, that they don't need to be considering doing home insemination. But if you are going to be doing home insemination, I guess, yes, timing for ovulation would be important in that scenario so that you're not doing lots of home inseminations unnecessarily. But I think really timing for ovulation are probably more than once home insemination. So maybe every day once ovulation is happening, every day for a few days. But I think also taking a step back and looking at can things be done to help reduce the need for you to be considering doing home insemination.
Okay, great. The questions are rolling in now, so I'm going to go as fast as I can through some of these. So there's two kind of similar questions here. Does this mean that IVF can deplete your ovarian reserve if there are multiple rounds, if I've understood it correctly? And under the same vein, are there side effects to hormone injections for IVF?
Yeah, really good questions there. And I'm very aware I didn't mention side effects on the IVF side of things because I knew we were going to come on to this. So in terms of the first question about depleting ovarian reserve, it will make no difference. So women are born with 2 or 3 million eggs in their ovaries, and the numbers of eggs actually peaks before birth, and then it starts going down from before birth. And it's because the eggs, there's a process whereby all cells in the body essentially die off, and that happens with eggs as well for some reason. And the menopause happens when there's between 1,000 and 10,000 eggs left in the ovaries. Now, if you think about it, even if a woman was never on the pill, never got pregnant, so had a period all the way from the first period until menopause, she would have about 400 periods in her life. But you don't go from 2 million eggs down to 10,000 by only having 400 ovulations. So us retrieving 10, 15, 20 eggs during an IVF cycle makes no difference from that journey from 2 million down to 10,000. So there's no difference in the age of menopause for women who've had lots of IVF cycles or women who've been on the pill all the way from age 12 to 50 and have never had a single ovulation. It makes no difference. The second question about side effects, there are what are often considered more mild side effects, which might be maybe some breast tenderness and abdominal bloating, up to more severe side effects. The main one we talk about is ovarian hyperstimulation syndrome, or OHSS, which is when there's very severe abdominal bloating. And in about 1% of IVF cycles, women can end up with severe OHSS and can actually end up in hospital. Now, 1% sounds low, but it's not zero. And so what the clinic will do is to get you on the right drug dose based on your AMH level, which is a hormone level, and also monitor you very closely to minimize the risks. There are other risks to do with the egg collection, but there are a few in 1,000. So the main thing we watch out for is OHSS.
Great. And actually, usually they'll look out for it and stop the cycle.
Yeah.
It's far less common. There's a question here asking, does the fertility test predict fertility? We try, to predict fertility, but actually there is no real test for fertility. Fertility relies on both partners. So actually, even if you are perfectly fertile and your partner isn't, you are an infertile couple. And I think that's a really important disclaimer to make. And there is no current test that tells you the quality of your eggs. We can give you an indication, and we've worked really hard to try and rule out or try and think of as many different things that are associated with female fertility as possible when it comes to any infections, your menstrual cycles, your reproductive hormones, your ovarian reserve, your thyroid, all of the really important clinical parameters associated with good female fertility or female fertility. But at the end of the day, when it comes to predicting someone's fertility, if your partner has lower fertility or low sperm count, then actually there's no real test that can tell your fertility. We can tell you one side of the equation with good as good as we can do, as good as the clinic or as any clinic would do as well. But I would say that nobody can fully test one person's fertility because fertility is a two-sided equation. So just to state that there, we're actually working on a research study now to look at how we can actually develop an assessment of quality of a human egg by looking at the cells surrounding it. But it's still a lot of research to be done, but we will do our absolute best to tell you your overall reproductive health. So somebody has asked, with an underactive thyroid, if you have high antibodies but a 1.5 TSH, do the antibodies stop you getting pregnant?
Another very, very good question. So the main test to do from a thyroid perspective, and the thyroid gland is in your neck, and thyroid hormone has effects all around the body. It's a very, very important hormone in men and women. The general recommendation is probably on at least an annual basis. If you're trying to get pregnant, you have your thyroid checked, and it's a TSH is the normal test, which was mentioned in the question there. You really want a TSH of less than 4.0. If it's above 4.0, the UK guidance now is get on some thyroxine tablets to bring your TSH down to less than 2.5. Whether or not it's worth checking for antibodies as well is a bit controversial. It's not very clear. It used to be more widely done than it is now. If you have thyroid antibodies, they don't stop you getting pregnant. So having thyroid antibodies or not doesn't actually make any difference from a fertility treatment perspective. You don't have a different treatment. We don't give you any drugs because you have antibodies. But if you have antibodies, when you get pregnant, in pregnancy, there is more of a risk of your thyroid gland struggling. So women with thyroid antibodies, when pregnant, need closer monitoring of their TSH in pregnancy, and you are more likely to end up on thyroxine tablets in pregnancy.
And it's the #1 prescribed drug in the world.
Yeah, exactly.
So it's amazing to me that we don't routinely more screen for thyroid, because so many people have thyroid,
Yeah.
especially women. What is PCOS, and does PCOS affect fertility?
Good question. So PCOS is polycystic ovarian syndrome. It's the commonest endocrine or hormone condition in women, and probably around about 5% of women have full PCOS. Because it's a syndrome, it can be made up of a few different things. So some women will have some aspects of the syndrome. It doesn't mean they have full PCOS. So PCOS, you have to have 2 out of 3 things. One is irregular periods. The second is ovaries that look polycystic. Poly means lots of. Cystic is an old-fashioned word for follicle. So lots of little follicles on the scan. The third possible thing is having high levels of male hormone like testosterone, so higher androgen levels, which might show up as bad skin as well. So classically, your classic PCOS patient will have irregular periods and a lack of ovulation. So if you have irregular periods and a lack of ovulation, yes, that absolutely can affect fertility. But if you have regular periods, probably having PCOS, because you can have PCOS and regular periods if you have high androgen levels or an ovaries that look polycystic, then it doesn't really affect your chance of natural conception. But women with PCOS, when they get into fertility treatments, the clinic will be watching you very, very closely, because having PCOS, your AMH, your anti-Müllerian hormone measure of ovarian reserve, tends to be quite high. And having a higher AMH and having polycystic ovary syndrome does increase the risk of that complication that I've already said, which is OHSS, or ovarian hyperstimulation syndrome. So clinics will go very carefully with the dose for you. But when I have a patient who comes to me with PCOS, even if they've got irregular periods and they've just started trying to get pregnant, what I say is your chance of having a baby will be exactly the same as anyone else, but you might need some help with some medication along the way.
Great. Perfect. Actually, the study that we're looking at is comparing PCOS and non-PCOS eggs because PCOS patients get lots of eggs, whereas
Yeah.
non-PCOS. So we're trying to see, even though there's an abundance of eggs, is there a difference in the quality?
But the advantage of having more eggs, your study will show, I know, is obviously more embryos. You can then get more choice of embryos as well. And a big thing, it used to be thought, you'll hear some IVF clinics saying having low numbers of eggs collected is a really good idea. The HFEA data goes massively against that because the number of eggs you get collected is very related to the chance of IVF success in that cycle. Then also, if you're then looking at having your second and third baby from that IVF cycle, cumulatively, it keeps on going up and up. So egg quality, there may be a difference, I agree, but the number of eggs and therefore embryos is so important.
Yeah, yeah, for sure. Okay, so would hang on one second, sorry, trying to read it. How useful is your mother or sister's fertility as a guide for your own fertile age?
Very good question. So there is a strong link between age of menopause and your mother. So it's one of the main predictors, actually. So if your mother had an early menopause, so premature menopause would be before the age of 40, and early menopause probably between 40 and 45. So there is a strong link there. But in terms of fertility, because the average age, and I saw a question there was about someone who was 52. So the average age for the menopause, which is the last period in a UK population, is about age 51, 52. But fertility, natural fertility does decline before the menopause. So women getting pregnant naturally and having a live birth at the age of 45, 46 and beyond can happen. But the success of the chances are unfortunately relatively low or quite low. So I would say, yes, that I'm sure there will be a link between the age that your mum had her last baby at and your fertility. It's not that strong a link, but the age between the menopause and you is much stronger.
Yeah, it's one of the questions that we actually ask is about what age your mother went into menopause because
Yeah,
sometimes people will come to us and they'll say, well, my mum struggled to have me. So it's kind of a twofold question, whether if your mum struggled to have you, then the chances are actually likely that you might
yeah,
struggle as
yeah,
well. But
yeah.
also thinking of the
But
generation.
interesting. Interestingly, there's more of a genetic link between male fertility than there is between female fertility. So endometriosis, yes, absolutely, there's a genetic link there. Early menopause, there can be a link there, but the link between men and having issues with sperm production is stronger actually because of things on the Y chromosome than you can find on the female side.
Um, I have lots to say about Y chromosome. I
Uh,
did give a lecture today in UCL
yeah. Okay.
on Y chromosomal parameters. So, at age 35, with normal tests, both partners, after what length of trying to conceive do you generally start to consider IVF?
Also, a very good question. So the from an NHS point of view, they talk about 24 months, and that's because, as I said at the very beginning, roughly say 80% of people get pregnant after 1 year of trying. If all the tests are okay, then about half get pregnant in the second year of trying. So the NICE guidelines felt that it was appropriate to offer IVF if you're lucky and get through all the hoops after 24 months, because by then you're getting into your third year and your chance of natural conception is getting quite low. So from an NHS perspective, generally it's 24 months. From a private perspective, I think probably most people don't wait 24 months. I think a year would be quite aggressive to get into IVF after just 12 months. Uh, I would say for most people, somewhere between 12 and 24 months would be appropriate, but that then depends on other circumstances. Obviously, there's financial circumstances, how aggressive or not you want to get with treatment. Some people want to have their test and then they want to say, well, I want to give myself a bigger chance as possible naturally and only do IVF as and when. And that is then the horses for courses question.
Yeah, and I think there is more of a narrative. I'm certainly having more and more conversations with people who are doing IVF at an earlier stage, and they're doing it
Mm.
because they want to ensure that they're able to have further children. And so
Yeah,
already starting later for their first, what they don't want to do is rule out that they might be able to have, second
yeah,
and third children. So that's
yeah,
also one to bear in mind,
yeah.
or the rationale that people take into account is more than
Very
one
good.
child.
Mm.
So there's a couple of questions from individuals who are over 40, 45, 52. One is, I might be asking a question you've already answered, but I'm a 45-year-old single woman, female. In terms of having a baby using my own eggs, is that unlikely?
So, I mean, from a natural conception point of view, there are babies that are born to women at 45 and beyond naturally. So, yes, it can happen. If we're looking at a treatment perspective, an IVF treatment perspective, there've been a lot of studies from the UK and particularly from very good clinics in the USA looking at live birth rate per cycle for women who are 45, 46, 47, and it is low single figures. And that is down to the genetics of the eggs, really. You can try and start adding embryo biopsy in there and looking for chromosomally normal embryos. But the issue is that once you're into the mid 40s and beyond, the chance of finding chromosomally normal embryos does get down quite low. And you also, unfortunately, tend to produce fewer embryos in your mid 40s and beyond. So it can be challenging. So often clinics will start to talk about egg donation, which of course is not what people want, but the advantage of egg donation is the age of the uterus is irrelevant. So someone can be 52, someone can be 62. The success rate comes down to the age of the egg that made the embryo, not the uterus.
Yeah, and I think that's so often when there was an article that came out, I think it was like the New York Times, and they said, is the fertility cliff a myth? And all of a sudden everyone was saying there's no such thing as the fertility cliff, that your fertility doesn't fall off at 35. Plenty of people get pregnant after 35. And I think the point that was really missed is, yes, plenty of people get pregnant, but the incidence of miscarriage is higher in
Yeah,
those individuals. The number of abnormal embryos is significantly higher. And that's what I think the time delay is. As you get older, yes, you have fewer eggs, but that's compounded with the fact that they're of lower quality. So
yeah,
um
yeah.
we,
But I think people often, so many patients will say they'll have age 35 fixed in their head, and
yeah.
they'll be 34 coming up to the 35th birthday, and will think that that's where the cliff is. And that's not the case at all. There's a drift downwards, but it's not a cliff, it's just a drift.
That's exactly it. And I think that's what can be so scary for some individuals as well. I think some of our fertility advisors, they use me as a case study because they say, our CEO had a baby at 39 immediately. I think, we see it in our data. We have, you know, 39-year-olds with high ovarian reserve. We have 28-year-olds with low ovarian reserve. It really comes down to the individual, and your overall health as well. So not everyone should be afraid, but I think sometimes people are also the opposite, where they say, I'm just going to wait and see, maybe in a few years' time, and you think, no, no, listen, it's like
Yeah,
it's getting a little bit, and it's hard not to advise people and lend a little bit of fear to it. But equally, what
yeah.
you want to do is ensure that they're getting the true and honest picture of the chances. And so I guess starting by assessing your own risks and your own health is an important one to give you a better idea of that.
And I think alongside that, assessing everything, but also looking at your own natural health. So
Yeah.
own diet, Mediterranean diet, just get yourself fit and healthy. Definitely don't smoke. Vaping's not good either. Vaping's bad. So just focus on your own health.
Yeah, we've just submitted our paper showing that vaping significantly reduces ovarian reserve
Mm.
markers. We've also, incidentally, this is not published yet, but we will publish it. We looked at our data to see in any of the individuals who had done multiple fertility tests, if they'd done more than one and their AMH had gone up, what did any of those individuals, I think there were 600 people who had done it twice, and 600 people who'd done it and it hadn't gone down, it had gone up. And we said, what was it that caused their AMH, or potentially could have caused their AMH to go up? And the one thing that all of them had in common is that they'd stopped drinking alcohol. So even though we don't have huge bodies of evidence around the role of alcohol, many times people will be told just do everything in moderation. But we now are starting to see some evidence for complete cessation of alcohol intake, and actually how it can lend to a potential higher
Okay.
AMH, which is actually interesting,
Mm.
because so often I think that the everything in moderation can be really misleading, because what's moderate to one person
Mm.
might be excessive to another.
Yeah, true.
Great. So there's a question on at-home insemination kits. What's your experience with at-home insemination kits? Are they a good option for couples who don't have intercourse regularly?
I mean, I guess it comes back to the home insemination question that we spoke earlier on, and some of the kits now that you can buy they're sort of fancier, and the idea is they hold the sperm closer to the cervix, so they may well be better than just a syringe and you mentioned turkey baster I think earlier on, so may well be better than that. But I have also seen adverts from those companies suggesting that it's the same as IUI, and it's not the same as IUI, because in the end the sperm is just being put at the top of the vagina. It's not being prepared, and it's not going up into the uterine cavity. So I don't think it's going to be as successful. But obviously, it's much cheaper because you can do that at home. Is it better than intercourse for heterosexual couples in terms of success rates? I don't think so. I don't think there's any data for that. But if people aren't able to have intercourse or prefer not to have intercourse, then of course, then yes, that is an option.
Okay. Yeah, it's important to think about the sperm prep
Yeah,
for sure. You got rid of a lot of the debris and the dead guys. Okay. I'm going to try and get through as many of these as possible because just I want everyone to have their question answered, and there's a lot. So Tim, if you'll bear with me.
a lot of questions.
There's a lot of
Yeah.
questions, exactly. At age 35 with normal, oh, sorry, I've done that one. Sorry. My husband has poor morphology. We naturally conceived our son 4 years ago, suffered one miscarriage. Do you think IVF is the right way forward?
So morphology is interesting. So when you look at a sperm test result, the main bit is the sperm count, the motility, which is the percentage swimming, and the volume of the sample. And those three are the most important things. Morphology, which is the shape of the sperm, is not a great test, and it actually hasn't been shown in good studies to predict the chance of natural conception or miscarriage, because a man can have 96% of his sperm an abnormal shape, and that is a normal result, which straight away makes me think it's not a very good test. Because
Yeah.
96% abnormal is okay, but 97% abnormal is not. That doesn't make sense to me.
Yeah.
If men have all of their sperm abnormal, that can be a problem. So I personally, I would not base your decision making on having IVF or not based on that morphology result. I think have a chat with a fertility specialist and yeah,
Yeah.
discuss the pros and cons from there.
Yeah, I think it shows you the redundancy of an ejaculate. 60 million sperm per milliliter tells you
Yeah,
the majority of them are going to be redundant.
yeah,
Um,
yeah.
okay, great. I think is a woman in her late 40s wasting her time and money trying IUI or IVF given the reduction of success?
Late 40s.
Mm.
I the success rates are so low. I mean, it's always difficult. I don't want to be, doctor negative, but I also want to be doctor realistic and doctor transparent.
Yeah.
Um, Someone in their late 40s having IVF or IUI or paying for IVF or IUI with their own eggs, the success rates would be it's so low that I'd have to really question the clinic taking the money, to be honest with you. Unfortunately.
Yeah. And I guess it comes down to what their AMH would be and any of their other underlying hormones. If you had
To
to,
to to, to a degree, but again, the issue is even if you do PGT, so genetic testing of embryos, looking for chromosomally normal embryos, in some it depends. Someone's 48 or 49, the chance of finding a normal embryo is so low, it's problematic. So, I mean, hopefully you're having the person asking the question is having a really good, honest discussion with the clinic, and the clinic is giving you accurate success rates. But I think we have to be realistic as well. And I think no one wants babies through egg donation. That's not what you plan going into. But the success rates can be so good. And I've had so many patients that have built their families through egg or sperm or embryo donation and have, that's how their family's been formed and they're delighted with it. And I think sometimes it comes down to discussion about what's important to you.
yeah, exactly. And it's so, and I actually think it's important to have that discussion early on because
Mm,
so many people have an immediate kind of knee-jerk reaction to say that they wouldn't consider a
yeah,
donor egg or
yeah,
donor sperm. But actually, when they have those babies, it doesn't matter what the genetic origin is.
mm,
You
mm,
know, they are what you are going to nurture and
yeah,
they're going to be your children. Um,
yeah.
Okay, we have 3 minutes left, and I want people to get as good value as possible. How important is cessation of or moderation of nicotine and alcohol on men's sperm quality?
So
Very.
smoking is very, very, very bad for sperm quality. It alters the genetics of the sperm. Miscarriage rate is higher. Um, Alcohol, there is less research on that, I have to say. So I think my view, so low amounts of alcohol are okay. And I can take your point, Helen, about what is low, what is moderation.
Mhm.
I don't think for men there's any evidence that stopping alcohol completely compared to a few units per week is beneficial. But
Mhm.
if you feel better for stopping completely because that gives you more a feeling of control, then that's the right thing.
Yeah, for sure. I think it's so often underestimate the role of the sperm. The life
Yeah,
cycle of the sperm is three
completely.
months. So you
Mm,
can significantly increase the health and the quality, the quantity of the sperm in 3 months, as opposed to us carrying all of our eggs for as long as we've lived. And
yeah,
therefore,
yeah,
but that said, the life cycle of any follicle is 90 days. So again, for
yeah,
both that 3 months
Yeah.
preconception is such a valuable indicator for just giving yourself the best possible chance, especially if you're going through an IVF. So if you haven't yet given your both parties the best possible chance by eliminating any of your vices, really increasing just healthy food, reducing trans fats. Those are the basics. Like so often I look at fertility
Yeah.
conferences that you're at and you look at all of these amazing tools and you think, let's go back to basics. What are the things that any individual could do in the preconception phase to give themselves the absolute best chance?
Yeah.
It is really the boring stuff. Better
Yeah.
diet, better
Yeah.
nutrition, really making sure that you are giving your body the best possible chance to go into a conception.
There were some nice studies where there were couples with poorer quality embryos during IVF, and then they were then asked to follow a sort of Mediterranean type diet. And those that did follow it, actually, there did appear to be an improvement in embryo quality, probably both from the egg and the sperm side, but it does appear to make a difference.
Yeah, of course, it makes
Yeah.
absolute sense.
Yeah.
Mm, Dr. Tim, it has been an absolute pleasure chatting to you. I think
You can do one more. You can do one more question.
oh
Choose another
great. You
question.
you pick the question if you can see them because I can't see. Can you see them?
I can. I can. Okay. So, well, how many rounds of ICSI does it usually take to get pregnant? So, how many rounds of IVF for ICSI does it usually take to get pregnant? That is obviously so dependent on what the chance per cycle is, and the main driver for that is the age of the eggs, which unfairly is more important than quality of the sperm, but it is the most important factor. So, in a yes, someone who's under 35, probably the chance of having a live birth from one IVF or ICSI cycle now probably 35 to 40% for a cycle. So probably 2 cycles, whether that's fresh or frozen, would get you above 50%. You never get to 100% though, and that's always the problem. Now, as someone who's 40 years old, the live birth rate for one go at IVF might be 20%. So therefore, you can see it might be more goes to try and get up above 50% chance or so. So it is very much dependent on the age of the eggs and embryo quality and AMH and other things, but female age is most important.
Okay, amazing. If there's anything that we haven't covered, please do book in with one of our fertility advisors. They are a wealth of knowledge and equally book in with Dr. Tim with the Apricity team or Hertility team. And we really are on a mission to just help people
Yeah.
and give you as many answers and informed answers and balanced and evidence-based answers as possible. So hopefully we can
And
do.
I'm gonna get a plug in for my Instagram page here. So I do
Oh,
lives
please.
like this.
Absolutely.
I do lives just like this, but I don't get as many questions as this. This is good to see. But normally once a week, and it's Dr. Tim Child, Dr. Tim Child, one word, no S on the end. Uh, but certainly these sorts of questions, and I love doing these live with these really wide-ranging questions coming in, because I think as we've seen from this evening, the questions are from people starting very, very early on in the process, all the way through to people who've had a number of different cycles, different age ranges, and whatever. And I think, like you, Helen, just really keen to spread the word out there that there is information out there, and knowledge is power in this
Yeah.
situation. Absolutely.
Absolutely. I've put in the handle for your
Okay.
Instagram in the chat there.
Thank you.
And yeah, follow. We put a lot of educational content on fertility as well. So hopefully this is the first of many of these sessions and we can collate
Yeah, I'd
all
love to.
as
Yeah.
well and disseminate them and some educational resources afterwards. So thank you for joining us and hopefully we answered some of your questions and we're always here if there's anything else.
And
Take
good
care.
luck, everyone. Thanks for the
Yeah.
questions.